This presentation will describe a proposed framework for analysing military medical systems. The provision of healthcare for military service members is a widely accepted responsibility of governments. And these health systems are diverse in their hierarchical arrangements, beneficiaries served, medical facilities, operational capabilities, and relationships with the wider civilian healthcare economy. Such variation creates an opportunity for comparison, but so far, there have been far fewer comparisons of military medical services than those comparing national healthcare systems. This presentation describes a proposed framework for describing military medical services across the world in order to facilitate comparisons and collaboration between nations. The presentation will be delivered by myself, Professor Martin Brickenall, a Professor of Conflict Health and Military Medicine at King's College London, and by Mr. Ryan Leone, who undertook the majority of the analysis as a master's student at King's College London. Additional co-investigators are Dr. Zenobia Homan, Mr. Antonin Nalong, and Brigadier Retired Dr. Lutz Bandikow, the Editor-in-Chief of Military Medical Almanac Worldwide. Myself, Mr. Leone, Dr. Homan and Dr. Whitaker have no relevant financial or non-financial interests to disclose. Of course, Dr. Bandikow is the Editor-in-Chief of the Military Medical Corps Worldwide Almanac, but didn't provide any financial support for the undertaking of this study. At the conclusion of this activity, participants will be able to understand the value of comparisons between military medical systems, analyse the key features of a military health system, and evaluate these key features for planning a global health engagement activity. The presentation is supported by additional citations to academic papers that should be reviewed in order to achieve the full learning for CME credit. And the presentation links to a second presentation at this AMSUS conference titled Understanding Military Medical Services Across the World. This other presentation describes the research that informed the framework described in this presentation. And some material has been replicated across both presentations in order for each of them to be studied independently. So this presentation will cover the background to military health systems and comparing between health systems, and then look at sources, firstly the Almanac Military Medical Corps Worldwide, but also public information and internal sources. I will then describe the framework that we propose, and then my colleague, Mr. Leone, will describe the individual sections of the framework. And finally, I will close by summarizing the presentation and looking to the future. So the term health system, health sector, or health economy are used interchangeably to describe the range of stakeholders and actors within a state that provide health services for a country's population. The World Health Organization defines health services as service delivery systems that are responsible for providing health services for patients, persons, families, communities, and populations in general, and not only, and not specifically solely caring for patients. And this slide provides a conceptual framework for the breadth of actors that deliver health services within a country. Beyond ministries of health, the framework explicitly includes the potential role of wider actors, such as other government ministries, shown as the Ministry of Higher Education, Defence and Interior and Justice, the independent sector, and international agencies, non-government organisations, and charities. This framework provides an analytical tool to identify all providers within a country's health system to support comparisons both between and within countries. And the security sector is shown in the red box to the bottom left. Broadly, health services can be divided into state and non-state services. In principle, state services are funded by the Ministry of Finance through budget allocations to government ministries based on political choice using government income from taxation. And this is shown in the dotted Venn diagram right round the edge of the state sector. In some countries, compulsory contributions to social security funds may be managed separately from taxation income, and so we've shown a Ministry of Social Security alongside a Ministry of Finance. External donors may also provide direct grant support to government ministries, and non-government third-party funders, including non-public insurers, may also finance government-provided hospitals. And as I said, the slide also shows other government ministries that may use government money to provide health services. The Ministry of Health is often the focus for stewardship of the health system, including frameworks for regulation of healthcare workers, pharmaceuticals, and medical devices. The model also shows 4 types of health services: curative care, public health and prevention, emergency preparedness and response, and health education and training. These types overlap between providers, though the principal focus of policy and regulation is likely to lie within the Ministry of Health. The capability and capacity of healthcare workers is one of the biggest strategic challenges facing all health systems, and the responsibility for training the health workforce may lie with the Ministry of Higher Education rather than the Ministry of Health, particularly if responsible for healthcare education aligns with other undergraduate and postgraduate education programs within universities. And the setting for the education of healthcare professionals is obviously shared between university teaching environments and clinical settings such as teaching hospitals. And in some countries, these teaching hospitals might be run by the Ministry of Higher Education rather than the Ministry of Health. A much fuller reference to describe this diagram is shown at the citation at the bottom of the slide, and I would encourage you to click on the link and to read it, which is an open access paper. Now focusing down more specifically on security sectors and forces. The term security sector covers a complex network of institutions, forces and services that contribute to the security of a state and its people. It includes those managed at the national level, such as the armed forces, intelligence services, police, judiciary services, and border control. There may be other government-funded security institutions, such as a presidential guard, or those with a specific mandate, such as a gendarmerie for armed internal security. Some security services might be provided at regional or local level, particularly police services and prisons. Furthermore, in some countries, there may also be non-government providers of security, such as formal private security companies, informal community groups, militia, and personally employed guards. And therefore, the picture is one of civil security relationships, and with the slide just beginning to provide a framework for the breadth of these services. The Ministry of Defence, through its armed forces, is usually responsible for protecting the integrity of the country from external threats. Most armed forces have an integral medical service that both maintains the health of armed forces personnel and can also deploy in support of armed forces for operations. And the beneficiaries of the military medical system will include military personnel and may include their families, veterans, and civilian employees. And some military systems also treat civilians either on a private basis or as state-based funding. Military medical systems are often an integral part of a country's emergency preparedness and response system, as it's the only health system that is organized for field deployment and may be relatively uncommitted to the local civilian community. Moving now to the Ministry of Interior, this is usually responsible for internal security through the management of police services. Police services may be split by different functions, including border security, local policing, national response, and paramilitaries. And in some countries, the police services have their own medical system, just like the armed forces. Another security ministry, the Ministry of Justice, usually controls the judicial and penal system. This will include responsibility for the health and welfare of prisoners. And this is an often neglected component of a health system. And though prisoners may have unique health needs, such as mental health, that exceed that of the general population. And such, the health system supporting prisons should be considered as part of a country's public health system. And again, the paper cited at the bottom of the slide provides a fuller description of the term security health systems. So having set the context, now let's consider how you would compare between health systems. And in the civilian domain, several large databases and analyses exist to compare national healthcare systems. However, the information on each platform is variable and depends on data availability. Such analyses generally include information on healthcare access, spending, demographics, mortality rates, etc. The World Bank and the World Health Organization cover the most nations in the world, and the Organization for Economic Cooperation and the Commonwealth Foundation perhaps provide the most comprehensive information for the countries under their purview. Unlike national civilian health systems, military health systems have not been comprehensively compared across nations. The earliest comparison of military health systems was published in 1902 as the Handbook of the Medical Organization, Chiefly for War, of Foreign Armies. And the picture shown here is the cover page of that document. It describes the military health system of 20 countries and was a required study text in the Royal Army Medical Corps for promotion to the rank of Lieutenant Colonel. The Military Medical Corps Worldwide Almanac is the most current and comprehensive platform that documents the feature of international military health systems. And just for comparison, there are many organizations that provide an international comparison of armed forces and their capabilities. And the slide just shows the document titled Military Balance that's published by the Institute of Strategic Studies. So now let's look at the Almanac Military Medical Corps Worldwide. This is the only global listing of military medical services. While initially published as a paper document, it's been fully online since 2018. The publisher of the Almanac annually sends out a template requesting information from each country's military health system, and the results are presented online in a common format as country profiles. The Almanac contains 142 submissions on military medical systems from 132 countries. And there are more than one submission for Germany, Chile, Thailand, and the USA. And these cover each of their Army, Navy, and Air Force medical services. The Almanac lists the 22 countries that have no armed forces or military medical services. And there are 43 other states that are recognized by the United Nations but do not have entries. Each Almanac template requests that the country follows a basic structure. The first data set is a summary containing the country location, national language, country population, number of armed forces personnel, military hospital, institutes, medical services flag, and the name and contact of the Surgeon General. And then each entry has sections covering the basic tasks of the medical services, the organizational structure, military health facilities, military medical institutes, and a summary of the breakdown of medical personnel, and perhaps a final section on missions. Now, each country is responsible for their own submission, and so there's considerable variation in the actual information provided. All screenshots and photographs from the Almanac that follow in this presentation are included with the permission of the Editor-in-Chief. And before we move on, you might like to go to the website and review the entry for your country and consider how that entry aligns with the structure that we're presenting in this framework. But beyond the Almanac, there are a number of other public information sources. A simple Google search might identify additional information. And countries host some public information on official websites, both within the Ministry of Defence website and also as a discrete military medical services website. We show the website from France on this slide. There might also be information around healthcare for beneficiaries, including families and retirees. Information might be available from research databases, both in military medical journals and general medical journals. And finally, other grey literature might be available either from think tanks or from government reports. And all of the bottom group show examples from the United States. At the bottom, we cite a paper describing a methodology for searching for public information on the French and the German military medical system. And again, you might undertake a Google search for your own military medical system to review the types of information that come up on the search and consider how you might categorize each of those different sources. And the final source of information might be internal information. This includes books and other documents that nations publish by their military medical services and are either available as secure classified documents or available as publicly provided documents, but not easily accessible through electronic searching. And this slide shows a variety of different books published from different military medical services over the last 10 or 15 years. So now onto the framework. The framework is summarized on this slide here. The military framework is on the right-hand side, has the following sections. Section 1 covers the national context and summary. Section 2, the organizational structure. Section 3, the firm-based facilities, including healthcare beneficiaries and research capabilities. Section 4, operational capabilities, covering operational deployments and international collaborations and alliances. And finally, in this area, Section 5 covers personnel, with a subsection on recruitment and training and education. Section 6 looks at civil-military relations and the interface between the military and the national civilian health system. And finally, Section 7, which I've shown under Section 2, covers more culture and history and the informal aspects of power within the system. Now, all of these domains link to the WHO's 6 building blocks of a health system, shown on the left-hand side, and the dotted lines show where each of those domains would sit inside this military framework. So with that as an introduction, I'll now hand over to Mr. Lieni to cover each of the individual sections.
Thank you, Professor Bricknell. Now I'll begin to talk more about the specifics of the sections and subsections in this framework that Dr. Bricknell just described. Section 1 provides an overview of the unique characteristics that apply to healthcare for a country's armed forces. The size and likely missions for the MHS, or military health system, will be dependent upon this international and domestic security threats that determine the role of a nation's armed forces. This sets the requirement for healthcare for military personnel outside of a nation's borders, in overseas garrisons, and during military operations. This crucial role requires the rapid deployment of human and material resources and demands that key elements of the military health systems can be released from responsibilities for domestic healthcare provision. Beyond deployments, a military health system is primarily an occupational health service, maximizing the medical fitness of service members through health protection, prevention, and treatment and recovery for sick and injured service members. This is similar to a civilian health system, and this role will be determined by national public health services and social security arrangements. Depending on national circumstances, the military health system may also have discrete research, training, personnel management, healthcare information, logistics, and pharmaceutical services. The military health system will normally compete for resources from the defense budget rather than the health or social security budget. Therefore, its value and cost are measured against its outputs for defense rather than those for health. This section should answer the following questions. How are your armed forces organized? Where are the main organizations located? How is your military health system structured? And does the military and its medical services operate as joint or single services? Section 2 covers leadership and governance of the military health system. It should include a structural diagram and a narrative to explain organizational relationships. The civilian system is ultimately under the jurisdiction of the Ministry of Health. However, military health systems are normally accountable to the Ministry of Defense. The relationship between the highest military official and the head of the military health system is subject to variation and nuance between countries based on size and circumstances. The left-hand figure shows the possible organizational choices for military health services, using filled lines to suggest the military structure, dashed lines to indicate choices about relationships, and a dotted line to indicate the external connection from the military to the Ministry of Health. The diagram assigns the title of Surgeon General or Director Medical Services to the senior appointment in the military medical services. This reflects the dual role of the senior health advisor to defense as a staff function, providing health intelligence, planning, and logistical or operational insights to the head of defense, and the senior leader of the medical services as a chief executive function, controlling operational medical units, garrison healthcare, training centers, and research facilities. The choices indicated in the diagram reflect the range of different models of military healthcare systems. The image on the right shows organizational diagrams from Switzerland, Belgium, and Singapore, which illustrate the different structural choices. The third section covers community-based services within military garrisons, which may offer primary medical care, dental care, physical rehabilitation, and mental health, and covers hospital services. This is often the largest component of the military health system, and it is a vital component of the military service benefits. The recent paper cited proposes a model, the defense health cycle, to illustrate the relationships between the different components of a military health system that meet the health needs of different beneficiaries. You might review this paper to consider how this concept applies to your own military medical system, how it overlaps between firm-based and operational healthcare, and how non-military beneficiaries impact the costs and structure of the system. The structure and size of the firm-based or garrison health system is likely to be organized on a regional basis and aligned to the location of armed forces units. This might be shown on a map, such as the image here, taken from Brazil's profile. The beneficiaries of the firm-based health system may dictate the breadth of clinical services provided, ranging from obstetrics to geriatrics, for example, and the overall cost of the military health system. This subsection provides a matrix to record the beneficiaries of the military health system. In addition to armed forces personnel, there may also be an obligation to provide general medical services to beneficiaries, such as family members, retirees, veterans, and designated civilians. It may also care for law enforcement personnel or VIP patients, such as royalty and elected officials. This list of beneficiaries is an important factor for comparison between military health systems. As a nation's military medical research capabilities and focus may be a significant additional component of the firm-based health system. Military research has facilitated significant advances in healthcare, from preventative medicine and vaccines to acute trauma care and specialist rehabilitation. This subsection lists possible categories of research in the military health system, including whether there are physical military facilities for conducting this research, funding for relevant civilian sector projects, and military-specific journals to promulgate findings. Section 4 covers the role of a military health system to treat and transfer casualties during military operations from point of injury through different levels of care back to the home nation. Medical units may be codified according to the capability descriptions in the NATO Allied Joint Medical Support Doctrine and used to inform national and international military capability planning, such as the NATO defense planning process and the EU capability development priorities. A description might be supported by a graphic that illustrates the national casualty evacuation concept, such as the US Army Health System operational framework shown on the slide. Importantly, it is recognized that a full description of the number and size of military medical units might be classified information. This subsection of Section 4 covers the participation of the military health system in supporting overseas bases, combat missions, UN peacekeeping operations, humanitarian or disaster relief operations, training exercises, and health diplomacy. To understand the scale of such commitments, it is suggested that the annual number of each of these deployments types is categorized by the number of missions and the level of resources committed each year. Additionally, the section could include a map to illustrate the breadth of their commitments, as shown by the image of health diplomacy activities by the Jordanian Royal Medical Services on the slide. Military medicine is often a significant topic for international collaboration to coordinate joint exercises, present research, produce standards, and facilitate collaboration in combat or disaster scenarios. This subsection of Section 4 covers the participation of the military health system in multinational medical collaboration, such as the NATO organizations, which include the Committee of the Chiefs of Military Medical Services, the Inter-Allied Confederation of Medical Reserve Officers, and the Center for Military Medicine. It may also include involvement in global committees, like the International Committee on Military Medicine, and regional congresses, like the Balkan Military Medical Committee. Section 5 covers the healthcare workforce, which is a key building block of the military health system and often the principal cost. In the World Health Organization's mapping of healthcare occupations, based on the 2008 International Standard Classification of Occupations, it combines armed forces providers under the title of Armed Forces Occupations. This consequently obscures the detail necessary to understand a military health system's capability. There are three unique personnel aspects of military health systems that should be understood. The first is that the combat medic, which are service members trained to deliver preventative, primary, and combat casualty care, is often a military job that is unique. Although similar to paramedics or clinical officers, their training and employment may not align well with civilian categories of healthcare providers. The second unique factor is the employment status of the personnel. Military systems may include active duty service members, reservists, or civilian personnel, with implications for their availability to work on overseas operations or domestically. The third is that serving military providers will have a military rank as either officer or enlisted. This may have implications for healthcare team structures and dynamics. A suggested list of professional categories is shown in the slide. This section should also consider the modes of training for military health professionals, including field training centers, military medical universities, civilian clinical placements, and possibly international placements. The slide shows images of military medical training being undertaken in Taiwan. As suggested for Section 1, the formal relationships between the civilian and military health systems are a critical component of the military health system. The COVID-19 crisis has highlighted the contribution of military medical services to national crisis response in various regions of the world. This slide, for Section 6, provides examples of how military healthcare efforts may intersect with civilian efforts to improve trauma care, coordinate disaster response, and facilitate the provision of subspecialty care that is beyond the capability of military facilities alone. The final section, Section 7, covers the cultural and historical features of a military health system that create a sense of unity, identity, and loyalty. The shared symbols of military culture, such as badges, mottos, and associations, may influence the perspectives of military healthcare providers. Additionally, the history of a nation's military health system may be a source of pride and a foundation for traditions, ceremonies, and rituals. This might be recorded in books or displayed within a military medical museum. You might look up the cited paper on this slide and apply the model for analyzing culture in a military medical system to your own nation. With that said, I'll pass it back to Professor Bricknell for the conclusion.
So in conclusion, this presentation builds on our companion presentation in this conference, and it describes the value of comparisons between countries' military medical services for both strategic analysis and also to facilitate collaboration between countries. It also describes the value of a common framework for description and reporting, including, in this paper, we've proposed a structure for this framework. The value of the Almanac Military Medical Corps worldwide as a host for military medical information has been demonstrated, and we hope that we can encourage members attending this conference to consider the key information that's shown in against their country's entry, and to consider adjusting it to reflect this common framework proposed in this presentation. And finally, we recognize the political and security constraints of full disclosure of information, and hence there will always be a difference between publicly available information and a full understanding of a nation's military medical system. So well done for getting to the end. We hope that you've achieved these learning outcomes from this presentation. Firstly, to understand the value of comparisons between military health systems, to analyze the key features of a military health system, and to evaluate these key features as part of planning a global health engagement activity. And finally, to claim your continuing education credit, you'll need to go to the webpage on the AMSUS site concerning this conference. So in closing, thank you very much indeed for your attendance and completing this presentation. Please contact me, Professor Martin Bricknell, if you'd like any further information on the material that we have presented, or to discuss academic study or collaboration in the field of conflict health and military medicine. Thank you again.